and then the Council and Head of Cooperation from the High Commission of Canada, Shauna Flanagan, also with us today over there. But really all of you are here as important stakeholders in this really important initiative, where we look at the insights that we have learned from Haiti, and also think about it as a window of opportunity to tackle the NCD burden, and how those two align very closely. I also want to particularly welcome Shane Norris and his team, and of course Stephen Lai and his team, the two co-leads of this particular work. As we so helpfully say in South Africa, all protocol observed, and for the rest of the meeting, feel free to be more informal and engaged, so that we all really can learn from each other during this particular time. Before I close and hand over, I just want to remind you of the slide that's up behind me. This is our health and history slide. Some of you may have seen it, but if you have not, it is a really important initiative of the South African Medical Research Council to acknowledge the role and the complicit role that the SAMRC played in the apartheid years, our silence during that time, but to recommit ourselves to the continued promotion of justice and dignity in health research in South Africa. And this is one of those initiatives that relate to that recommitment of ourselves in this direction. So I wanted to put that up just to set the immediate scene. And now it is my great pleasure and honor to hand over to our Deputy Minister, the Honourable Dr. Joe Phaahla. Thank you so much.
Good morning, ladies and gentlemen. Thank you very much, Prof. The Vice President of the South African Medical Research Council, all our partners in this meeting of today, from Wits University, Professor Shane Norris, from also, as the Prof has already indicated, also partners from the Canadian High Commission, Trade Office, from corporate, from Head of Corporations, also from the High Commission of Canada, and all the other partners. We're looking forward really to the reports and the discussions this morning. I've been asked to reflect briefly on our own activities as National Health Department in our battle against non-communicable diseases. I'm really pleased for the invitation, and I'll really just give a broad overview. And I'm pleased to be here because indeed non-communicable diseases are a major component of what we call the quadruple burden of disease. South Africa faces 4 streams of a burden of disease, with non-communicable disease as being a component of that. Also, of course, on the communicable side, as you know, we have a huge burden of HIV, AIDS, and TB, especially on the infectious diseases side. Of course, also we're dealing with a major challenge in terms of improving our maternal and child health, being the 3rd stream. And then lastly, huge burden also in that quadruple being trauma and violence, including motor vehicle accidents, that constitute the high burden of disease. So today here we're focusing on one component, which is the non-communicable diseases, and amongst those being diabetes mellitus, hypertension, cardiovascular diseases, chronic respiratory conditions, and cancers being amongst the leading causes of death in South Africa today. In particular, diabetes remains the 2nd leading underlying cause of death, especially when we look at just looking at the reports from Stats SA in 2020. standing at 6.6% of all deaths. In that period, just trailing COVID-19, which was the highest killer at the time, but now we know that with COVID having faded out, diabetes is a leading cause of death amongst South Africans. When we look at the gender-specific aspects, also we see that diabetes is the leading cause of death amongst females at 8.2%, having increased, that was in the 2020 stats, having increased from 7.7% in 2018. So the rate at which diabetes is becoming a dominant cause of death is actually concerning in our country. Non-communicable diseases do not only contribute to reduction in life expectancy, but also have a profound economic impact, straining both individuals, but also our own health system as well, under a lot of stress in this regard. It's crucial that we recognize the gravity of the burden of non-communicable disease, which has got also interconnected factors, as we know, the causative factors such as diet, unhealthy diets, lack of physical activity, also substances, especially alcohol, unhealthy use of alcohol, smoking, especially with chronic respiratory, obstructive respiratory diseases, also social and also commercial determinants which contributes towards NCDs. As a Department of Health, we prioritize NCDs as a huge component of our healthy living and improving the quality of life of South Africans. Our approach is comprehensive and multifaceted, recognizing that tackling these conditions requires a sustained and collective efforts across the continuum of care, from prevention and early detection, but also making sure that we have effective mechanisms for treatment and management. But our primary focus, really where we try to put as much effort as we can, not always successful, is in prevention. We have implemented public health campaigns aimed at promoting healthy lifestyles through education on healthy diets, regular physical exercise, and avoiding harmful substances, as I've mentioned, such as alcohol and tobacco. We are encouraging South Africans to make healthier choices. And it's important that we emphasize that healthier choices, including healthier diets, are not necessarily always expensive. There are ways in which some of this, including even on the dietary side, do not necessarily carry a heavy financial burden. Our collaboration with various government departments also is, as we take this campaign forward, together with our colleagues in education sector, both basic and higher education, sports and recreation, and also especially social development department. But in the same way as we've learned effective ways to mobilize society, we again use the approach to say, in the same way as we fought against COVID, we must use an all-of-government and all-of-society approach if we're going to succeed. Early detection of NCDs is very key. Our department has rolled out community health workers and also trained, quite interestingly, we must admit, not necessarily at a very large scale, but there has been steps which have been taken, and we also engage even in the formal meetings with traditional health practitioners. And some of them have come forward to take lessons and accept equipment to measure blood pressure, and also to learn how, also as they do their traditional ways, also to check blood sugar levels. So, and they've accepted where they find something that they should refer their clients to our health facilities. Of course, I must just mention on the traditional health practitioners that it's not always easy. I met with them sometime just before the elections, and one of their complaints is that they refer their patients when they find something to us, but we hardly refer to them. And they say it's a one-way track. They want to see a stage where our health practitioners will also write referrals to them. So this initiative is bridging the gap between health services and communities at risk by making screening services as accessible, especially those in underserved communities. We have already conducted campaigns, not yet completed. We've done so in KZN, Mpumalanga, Free State, but we are continuing in the other provinces as well. Although we focus on particular districts when we are in a province, we have an understanding with those provinces that these are really just in terms of as a dry run, and when we finish in those districts, the provinces will carry on and complete the rest of the rest of their districts. Our focus is not limited to detection of disease, but also includes health education on risk factors and lifestyle modifications that can prevent the progression of this non-communicable disease conditions. Our department has recently entered into a memorandum of understanding with an organization some of you may be familiar with called parkrams, to encourage communities to utilize open land, whether in a formal park or if it's just open land, and extend the establishment of these activities under the auspice of parklands, not only in the suburbs but also in the townships and villages, to encourage a culture of physical activity, walking. Don't always have to run. Those who can run should do so, jogging, afternoons, and especially on weekends. Parklands are very positive, welcoming, and because it's a very relaxed atmosphere, there is nobody is late. As we walk together, everyone is a winner. So this is what we're hoping to expand together with the organization Parklands. So at the heart of our NCD response is strengthening our primary health care services. Our PHC facilities across the country are being equipped to manage and monitor patients with chronic conditions effectively. Our department is working to ensure that also treatment is accessible where it's needed and affordable. At our primary health care facilities, of course, all services are free of any financial cost. We have made significant strides in ensuring availability of essential medicines in all our facilities. I can say that even outside government organizations, which many of you would be aware of, some of the NGOs which have been monitoring availability of medicines, and when of late when we have met with them, they have indicated that they're quite satisfied that there is very, very little, if any, stock outs of essential medicines. So which works very well also in managing non-communicable diseases. Supply chain for chronic medication has been strengthened, and we have continued to prioritize availability of these essential medicines, especially for NCDs, such as diabetes, hypertension, cardiovascular diseases, and so on. We are aware that in some areas we have been made aware that we also need to update our essential medicines list. We do have a committee of experts who advise us on essential medicines, and we have brought to their attention that continuously they do revise the list of essential medicines, because there's always improvement in various medicines. I must also mention that a program which is called the Centralized Chronic Medicine Dispensing and Distribution, which takes medicines to communities. It's also very useful, so because many of those who are stable are able to receive medicines without necessarily having to visit our health facilities. We also lead the way in the regulatory side, because we're not only promoting, but also as a government we have to also regulate. We've intervened together with other colleagues in Treasury, for instance, in terms of the tax on sugar-sweetened beverages. We have also published a number of regulations, which I'll just touch on. Regulations to regulate trans fat foodstuffs. That has been done. We among the leading countries in this regard. Regulations also in as far as the content of baby feeding, so that we can make sure that processed baby feed is also, in line with proper nutritional requirements. This we have done. Also relating to reduction of salt in various food, especially prepared food. We are aware that a number of preserved food, especially some of the snacks, there's a lot of salt which needs to be monitored. So we've published regulations in that regard, trying to make sure that South Africans should not consume more than 5 grams of sodium chloride per day. So these are some of the interventions which we have made. Scientific evidence suggests that reducing this level of salt intake significantly reduces the risk of especially high blood pressure and other cardiovascular diseases, which also can lead to coronary heart disease. So we are amongst, one of the few countries which have put formal regulations in this regard. Last year, we also published draft regulations to improve food labeling requirements so that consumers are clear about contents of food. The regulations include a model to classify healthy foods, specifying criteria for health claims, and a mandatory front of pack label in the form of an easy to understand logos to assist consumers in identifying foods that exceeds the thresholds, which we have said, whether we talk about sugar, trans fats, and salt, all those. So we've made it compulsory that producers of food should actually put very clear labeling, which makes it easier for people to read and understand. All the regulations are crucial in curbing NCDs. However, we accept the fact that we are lacking in as far as monitoring. We need to work together with other colleagues in municipalities. I'm sure many of you would also be aware of a lot of outcry in as far as monitoring of food outlets, especially in schools where children have got sick, and in some cases, unfortunately, some even died from some of this. So we're working together with other colleagues, trade and industry, Home Affairs, and police, over and above our environmental health practitioners at municipal level, to make sure that those food outlets can be monitored to comply. So at the current moment, we acknowledge the fact that monitoring compliance is not yet up to scratch. But we also acknowledge the fact that addressing NCDs cannot just be a work of health department, not a work of government alone. So social and commercial determinants of health, such as poverty, levels of education, access to clean water and sanitation, and also access to the very nutritious food, it's not something which can be achieved by health sector alone. So that's why I've mentioned earlier on that. So the idea of all of government and all of society is very important. So for this reason, as a department, we work closely, and I'm happy to know also here that we do have representatives from the World Health Organization, UNICEF. We work with UNICEF as well, to make sure that you can always learn the best practices from the global experiences of these organizations. We are making efforts to improve how we engage with stakeholders involved in the prevention of NCDs. Just last week, we placed an advert on newspapers inviting stakeholders to a meeting to discuss how best we should coordinate our work. We will be hosting a national cancer meeting from the 16th to 17th of October this year to discuss and agree on cancer coordination programs and structures. The outcome of this meeting will help us to provide better support and especially assist many of the organizations doing work on the ground to be able to access funding. We need to take advantage of the health promotion levy, which the sugar tax, as is often called. We acknowledge the fact that we have not made really good enough use of that. It collects somewhere around, I don't know, close to about 2 billion rand, which goes to Treasury. We get a minuscule of that as a Department of Health. So we want to be able to show cause why we should receive much more of that so that we can do this work and hopefully be able to also assist NGOs which are doing good work on the ground. Hopefully working together we can be able to do that. But we also, I must say that all this work we need to make sure that we've got good quality information. And therefore I'm looking forward today in this meeting because data is very key if we're going to make the right decisions. So I'm looking forward to this, the report today of the Healthy Life Trajectories Initiative, the data which will be reported here, which will help us to plan better and intervene better in our work. Also, the focus of the Healthy Life Trajectories on gender-responsive interventions also will be very important because we know that the needs of for women and men may not be the same, boys and girls. We all need some unique messages and interventions to have behavior changes. So we're hoping that this report will help us to get closer to that. So this battle is far from over. We've made some strides. We believe that there is some progress which we have made. As we know, all of the NCDs are exploding. I've mentioned diabetes, cardiovascular, but we also know, especially also malignancies, on significant rise. And we see a number of reports from our own data, but also just anecdotally, as we see, even many of you would be aware that just a few days ago we lost one of our colleagues in government, former Minister of Public Enterprise and Finance, Minister Kodan, who also succumbed from cancer, which was not detected early. By the time it was detected, it was already spread to the lungs and other organs. So this is just a reminder that this is a real fight we have in our hands. No one is spared, no matter your level of education and level in society. These are diseases which are a threat to all of society. So I'm looking forward eagerly to the reports for today, which I hope will help us in this battle to fight against non-communicable diseases. Thank you very much.
Thank you very much to the Deputy Minister for those words and for outlining the Department of Health's approach to NCDs, which you can hear is extremely comprehensive. And I think for those of us in the Medical Research Council, which is really important, is evidence-based and data-driven, which is really the way we're going to approach today as well. Also really appreciated the all-of-government, all-of-society approach. So here we have a representation of that as well. And then finally to bring it to walking the talk, or as the Deputy Minister says, getting involved in the park run or park walk. This is a marathon, and together we are all undertaking this marathon. So we will reach there as long as we have all of these steps in place. So thank you very much again, Deputy Minister. I also want to reflect on the fact that in this room we have many different types of stakeholders. We've heard that we're going to hear next from the WHO, we've got UNICEF, we've also got members of the national departments of health in the provincial level in most of the provinces as well. So just want to acknowledge your presence and thank you very much for being here today. And now I'm going to hand over to Nigel Rowlands, who's going to give us some few words from the WHO perspective.
Deputy Minister, senior officials from the Department of Health, from the Canadian mission, and several friends and colleagues from SAMRC. It's always a delight for me to be here. Some may know that I lived in Durban for close on 15 years, working in King Edward, and so South Africa is very much part of my blood. And my children were all born here, so it very much feels like coming back. So I'm delighted to be here. And I'm delighted that my colleagues, Dr. Rosalind Doe and Joseph Mwangi, are here from the WHO country office. So we are here very much to support. I want to, just in a short time, just share a little bit about what Dr. Phaahla was referring to as the Healthy Life Trajectories Initiative. It's a long phrase, and so we just bring it down to healthy. But in a few minutes, I just want to give you a little bit on the background, how Healthy was established, including in South Africa. What do the Healthy projects actually look like? Why are they? I think they are exceptional. I was talking with a colleague and say I almost never use the word unique. But Healthy is truly exceptional in a way. And it's a lot more than a research study. It's really is what I would consider now a true learning environment for many different things. And then really just to reflect on everything that the Deputy Minister was sharing about those comprehensive approaches, about the importance of prevention, where are things going in the future, the tension and challenges with the health systems, and it's great that there's representation from each of the provinces or from most of them, because that's really, as I think the term is used, when the rubber hits the road, that's when that's when you really see. So the background to Healthy was that in 2012, our department, I work in maternal child health, and we have a strategic group of experts that come and meet with us every year. And we were asked the question in 2012, so what are you doing about the global epidemic of childhood obesity? And it was a room just like this, and there was probably about the same sort of number of people, maybe a few more, and people were looking round from the department at each other, and we just had to say we're doing nothing. Our department about maternal and child health was doing nothing about the global epidemic of childhood obesity. And so we said that that is just impossible to be in that situation. So the first thing that we did was that we wanted to learn about the pandemic, and so very rapidly we brought together a panel of experts from all over the world, including South Africa, to really understand the problem. And a lot of the discussion focused on the emerging evidence. And there was one particular area that I think many people, and absolutely including WHO, had a complete blind spot on. And it was this whole area of preconception health. And this is David Barker, who was an epidemiologist, and he had looked over decades at data from here and there, and he recognized that the health of women during pregnancy and not only during pregnancy, but before even becoming pregnant, at the time of conception, that the woman's health and nutritional status appeared to translate into the lifelong health of her offspring. That if she was micronutrient deficient, if she was somehow stressed, that somehow impacted on some of the early programming of the child. And so, reaching my age, whether I have heart disease, whether I have hypertension, whether I maybe even have diabetes, some of that can be traced right back to the well-being of the mothers at the time of conception. And this was then converted into the term the developmental origins of health and disease. And this included environmental exposures, not just the food that she was eating, but other exposures as well. And so just very, very briefly, and this is where I was on a learning curve, we all know that we have genes. So here are the genes all around here. And we all say the genes can never be changed. But actually the spaces in between the genes on the DNA is called the epigenetic area. And the critical thing about those epigenetic areas is that they can switch genes on and they can switch genes off. And those environmental exposures, the well-being of mother, her nutritional status at the time of conception, can impact on the epigenetics of the baby. And so those things can impact on the lifelong trajectory of that child. And this has been an area where there has been growing evidence. So this is maybe a slightly strange slide to put up on a presentation like this, but WHO has 6 core functions. I don't think I've ever seen a WHO colleague present these in a meeting. But this is WHO's bread and butter work. This is what we are supposed to do. The first thing is to provide leadership on matters critical to health and engaging in partnerships where joint action is needed. We are also responsible for shaping the research agenda and stimulating the generation, translation, and dissemination of valuable knowledge. And then we are responsible for setting norms and standards, guidelines. There's other things there as well. But we were asked, what are you doing in terms of childhood obesity? And we said nothing. We weren't providing leadership. We weren't engaging in partnerships. We weren't involved in research. We weren't involved in setting any guidelines. And that was a major omission for WHO. And so we were challenged to say, what are you going to do next? So, through a variety of circumstances which we don't have time to go into today, and it was very, in some ways haphazard, it was lucky that we met with some colleagues from the Canadian Institutes of Health Research. That stimulated a set of decisions. We then, from the WHO side, we convened representatives of government as well as scientists from China, India, South Africa. We actually engaged Brazil as well. Things didn't work out with Brazil because of a variety of reasons. And in principle, we agreed to collaborate. So the president of the South African Medical Research Council said, this is going to be an issue for South Africa. The whole NCD burden, even back in 2013, was evident. And the need for evidence to inform policy was absolutely clear. And we didn't see much happening in this whole area of preconception health. And so there was an agreement between the Canadian Institutes of Health Research, the National Science Foundation of China, the Department of Biotechnology in India, and the SAMRC, together with WHO, to form a collaboration that was called Healthy. And only then, because each of the funders committed funding to research, only at that stage was actually there a call for researchers to get involved. So it was a different way that things often work, where government and funders came and collaborated and then pulled in the researchers. Most times it is the researchers who bring themselves together and then reach out to everybody else. So it was a slightly different way. And then the sites and the projects were selected in 2014. So what do these projects in these 4 countries look like? Well, they are all randomized trials. So that's already telling you the commitment to high quality evidence. They recruit women pre-conception. So you have no idea who's going to ever become pregnant, but you're recruiting pre-conception, so young women. Baseline characteristics were collected, and then Deputy Minister Phaahla was referring to behaviour change. Because those things around physical activity, diet, nutrition, you know, I think about myself, I close my jacket to hide the fact that I'm overweight. But you know, as much as I am motivated as a medical doctor, and I know this better than probably many people, it doesn't change my behaviour. So what is it that actually takes us? It's more than money as well. It's more than cost. There's many things. So what is it that drives young people especially to adopt change in behaviour? And so in South Africa, the name here is Bukali, Living Your Best Life. And they used a whole communication strategy called Healthy Conversations, which was sitting down with young people, young women, discussing their priorities, identifying the changes that they wanted, developing a plan together with them, not me coming and saying to you, do this, do this, do this, it's a smart idea, but working with whatever they were motivated on and then supporting them. And this was being done through the equivalent of community health workers, young women and men from Soweto. Not people with tertiary degrees or anything like that, young men and women. In addition to that, they were looking at the effect of micronutrients, because that epigenetic area, there's some very important sort of processes that are dependent on certain vitamins. Data is being collected on women. It was about hypertension, diabetes, depression, anemia, HIV and obesity, every one that the Deputy Minister mentioned. On the children, body composition, metabolic health, diabetes, insulin resistance, things like that, and also early childhood development, because everybody wants their child to develop well. And then, if you think about it, if you're recruiting women pre-conception, you don't know who's going to become pregnant within 12 months, 18 months, some do, some don't. They then become pregnant, you've got 9 months, you then want to follow the children for 5 years. These women are in this research study for 8 years or more. And that's why this research is exceptional. So I don't know of any intervention trial, randomized trial, where people are in the trial for 8 years. It is truly extraordinary. But that's not where it stops. Because not only would this be true of each of the 4 studies which are working in parallel, but all the interventions, all the data collection, all the biospecimens are harmonized. They're being collected at the same time in all 4 countries. And therefore the power and the ability to look at things across culture will be enhanced. So I spent all day Friday and all day Saturday speaking with and listening to the teams in Soweto. And I'm just going to give you, because you'll hear more through the course of today, but 2 things I heard that I thought really convinced me this is not just a research study, this is about learning. So the first thing is that they have data on young women, say 22. They also have other data from elsewhere on women of 55. In Soweto, although the prevalence of hypertension is higher in the older women, young women already have a much higher prevalence than would be expected anywhere else. But it's more than that, and sadly it's worse than that. Because the women of 22 have the same burden of risk as the women of 55. Which means that although at this moment in time the numbers are not good at 22 or 55, it is an absolute certainty that the number of women who are going to be hypertensive is not going to remain at the levels they are at the moment. They are going to increase significantly. over this next 10, they're going to accumulate and aggregate. And so all of those things, and the risk factors for hypertension are shared by things around cancer, about other things as well. Same story for depression, in terms of that burden of risk. The second thing, however, is not just that Aristotle had there was a saying by him, he said that the worst inequity is to treat everybody the same. And actually what they also learned is that there are some really important differences about diabetes. For the older woman, the main cause has been lifestyle issues, diet, gaining weight, etc. But there are a proportion of young women who are getting diabetes, and this is actually probably more biological, and that may come back to the whole preconception and the predisposition to things like diabetes once you go into an environment that is not terribly health friendly. This is what you call epigenetic predisposition. It's when your epigenetics at the time of conception are set because of their mothers, that intergenerational phenomena, now impacting on that woman. So really just wrapping up, why are these insights already valuable? They tell us, I think, pretty clearly what's going to happen over the next 20 years. Hypertension, heart disease, depression, cancer. And the Deputy Minister referred to how all of government, one of the very clear things is that these risk factors, although they are health outcomes, they are not being driven by health issues. The commercial determinants of health is massive and has been largely overlooked in most countries. And the economic power of these multinationals can influence things more than countries. And next year there's going to be the first global report on commercial determinants of health. But it means that the response has also got to be all of government and all of society. Prevention, you can't even have it as an equal partner as detection and treatment. For the likes of NCDs, it has got to be the mainstay. I remember when living here, people say you won't treat your way out of the HIV epidemic. It is absolutely clear you will never, ever, ever have the capacity to treat the future numbers of diabetes and hypertension. The only solution is to have a 10-year plan, a 20-year plan for all of those behaviors. Marketing can do it because they have sustained funding. They have all the experts in behaviour change. And that is the type of challenge and investment needed for health. And really just last to say, it requires that multiple sector approach. It's too early because they haven't reached that time point to know whether healthy conversation brings about the behaviour change, whether the micronutrients impact. That's coming very soon. But already you can see that young women and the young men recruited from the same communities, properly trained, properly supported, properly managed, are very effective in what they do in terms of bringing about change here and now. So I'll just conclude by saying I think Healthy South Africa is way more than a single research study. I hope you will recognise that today. It's about a learning environment for all of South Africa. Soweto is not exceptional. It is very true, and the truths that you can learn from Soweto are definitely applicable elsewhere. The team, because I know them, are willing partners to and one of the main purposes of this afternoon is to hear from you what are the data, what is the evidence that you need in order to inform your work. And so in that sense it is an example, an exemplar of how research can inform policy and practice, but more critically about how policy and practice needs to direct and engage with research. So thank you very much.